So, first of all, thank you, Emily and Neil, for asking me to come and speak to all of you today. I'm Manoj. I'm one of the surgeons at ARI, and you're probably wondering why, of all people, should a surgeon from ARI especially be here talking to you about human factors. My defense only joined recently as a consultant. But the reality is there are challenges that we face in the health sector which are very similar to the challenges that you face. And what I intend to do today, or what I've been asked to do, is to give all of you an overview of what we actually do in the health sector. And I've got to say, Aberdeen has always been leading that way in terms of understanding of human factors, systems perspective, especially in the healthcare with the great work that Rona Flynn, which some of you may be or know of, who's been doing in the last decade or two. So really, I'll start off the talk, but please don't hesitate to stop me if you have any queries or if I'm not being clear, or if indeed you can't hear me. I always put this slide up when I do talks with other industries, because this is what people think, or this is what we look like. Clearly not. Though somebody once told me I probably look a bit like him, but the reality is what we see in the media or how the health sector is portrayed is really not necessarily what the true nature of the health sector is all about. We in the NHS are not too different from health sectors anywhere else in the world. We face the same challenges, especially at this present time with regards to resource, money, etc. So I thought what I'll do is give you, I appreciate most of you have got backgrounds in human factors, so I apologize if I'm saying things that you already know, but I thought we would start off by just giving ourselves a quick refresher on human factors in general. So there's a lot of definitions, as I'm sure many of you are aware of. This is one from the nuclear industry. It says human factors concerned with adapting technology and the environment to the capabilities and limitations of humans, with the overall objective of improving the whole human technology system. Quite a lot to take on. And then you look at the definitions that we've put in healthcare with regards to what we think human factors is all about. So human factors is enhancing clinical performance through understanding of effects of teamwork, tasks, equipment, workspace, culture, organization, or human behavior and abilities, and application of that knowledge in clinical settings. Once again, a lot to take on. My background, really, I'm a general surgeon, but as a trainee, I did the unthinkable. And after, I don't know if you know, but as part of being a surgeon, we have one of the longest training. We indeed have the longest training time, if you like. So we finished medical school, and then the majority of us spent anywhere between 8 to 16 years training after that before we become a consultant. It makes us bitter, obviously, as you can tell, right? The reality is, when we are still junior doctors, most of our colleagues in medical school are already fully fledged GPs, making a lot of money running their own practices, or consultants in other specialties. On top of that, we're also expected to do research. And so we do our research. And then I did the unthinkable after that, where I went and did another degree. I did a master's degree in human factors and patient safety. And at that time when I did it, I'll be very honest with all of you, I was a very cocky junior doctor. Well, the cocky bit's not changed, to be honest with you. It's still there. But nevertheless, I went into this course in the University of Aberdeen with Rona Flynn, Steve Yule, a lot of amazing people. And I thought, what are a bunch of psychologists going to teach me that I don't already know, right? I am a surgeon. And then how wrong I was. So I spent 2 years doing part-time, spending my annual leave, much to the unhappiness of my wife, and did this degree in human factors. And I've got to say, it's an eye-opener. It made me look at things very differently than I would have had I not actually done this. The way having done that 2 years of that degree, I've got to say, I still struggle with the concept of human factors, the understanding of human factors, its application in healthcare, etc. And we can simplify all those definitions really by just thinking about three things. So it's the people, the workplace, the organization. And this was my starting point in my understanding of human factors and its application. So how do we optimize these three key principles such that we can have an effective workforce, such that we can have better patient outcomes or better outcomes in anything that we actually do? Now, on top of that, there's this element of non-technical skills. A lot of times when we talk about human factors in the health sector, what we're actually talking about is non-technical skills, which is just one element of this big topic on human factors. But we tend to focus a lot on non-technical skills for relevant reasons. So non-technical skills, they've defined it as a cognitive, social, personal resource skills that complement technical skills and clinical knowledge and contribute to safe and efficient task performance. Once again, a lot to take on, but hopefully I'll give you a quick overview of what we're actually talking about, what we're actually doing, and how we're doing it. So why human factors? Why in healthcare? I'll give you half a minute to have a read of this. I'm sure most of you may be familiar with that. It's an output from an adverse event analysis or review. So I put that slide up when I'm actually training doctors, surgeons, or other health professionals, etc., in non-technical skills in human factors for one reason and one reason only. Anybody familiar where that output's from? Yeah, it's a challenge. The thing is, when I put this up and I ask colleagues, where do you think this is from? Unanimously, always people say, oh, it must be the Department of General Surgery, right? Or some people say it was radiology, some people say it's something else, etc., etc. It was actually this. And I actually put that slide up for a very important reason, is that when we started talking about human factors in healthcare, a lot of the work, as you're all probably aware of, on human factors and non-technical skills have come from, though it's been in existence for a good few decades, a lot of the work has actually been happening in the airline industry, the aerospace industry, etc. And a common theme that crops up is people in healthcare ask me or ask my colleagues this question, is that it's all good you talk about how people fly planes or what else they do, but that's not medicine, that's not surgery. And actually, it is, because if you look at the failings that we have in healthcare, or the shortcomings we have in healthcare, it's exactly the same as the shortcomings that you see in your industry or the airline industry sees, etc., etc. So whilst we are not asking people to fly planes, we're actually asking people to appreciate the challenges or the issues surrounding human factors. So we talk about turning points. You know, events that has actually occurred anytime in your industry or in history, etc., that was defining, if you like, in terms of people paused, stopped, and realized, hang on, this isn't working, we need to do something else. And every industry has seen that. So you've got the nuclear industry in Chernobyl, you've got the KLM flight in the 70s, look it up on Google. It's got a good narrative as to what's happened. Then obviously all of you are familiar with Piper Alpha, what happened, the plane crash we had a couple of decades ago in England. And my favorite, which was my turning point, which was putting petrol in diesel car, right? And I've got to ask all of you, it's your area of specialty interest, why has no one changed the design of the nozzle for diesel and petrol? You know, why are we still having the same nozzle? I never understood that. But anyway, these are turning points, if you like, in all of our industries that people have stopped back. I heard recently a good talk by someone from the Formula One industry, and they described their turning point as Ayrton Senna's crash. Some of you may be familiar. I remember that. And that changed the landscape of safety in Formula One. The challenge we have in the health industry is, what is our turning point? We ask ourselves that question every day. We do see complications, we do see adverse events, but what exactly has been the turning point, or have we already seen that turning point and perhaps not noticed that? So we know human factors is relevant. When people started, this is a good slide I put up, and it's essentially coming off from the airline industry once again. And they used to build great planes, or they used to build planes, and planes were crashing. And then they realized there were issues with the technicality or how they actually built the planes. And then as they got better at building planes, planes still crashed. And then they realized, we've already built a great plane, why is it still crashing? And then they realized there was a huge element of non-technical skills and human factors behind the reasons plane crashes. And more we know that's not just the airline industry, it happens in all of our industries, that's the reason why we're still not performing well. So where we are in the health industry, I put the slide up also whenever I do these talks. It's purely to give people an idea of the challenges we face in the health industry. This is just UK data, and it's actually now a good few years old. But if you look at the scale of the challenges, we've got a whole load of people, and out of that, we've got pretty much tons of things that can go wrong, and this is on one individual, if you like. And on top of that, you've got thousands of drugs, not interventions, just drugs alone that can be offered to treat this 10,000 plus conditions, 140,000 plus conditions that can happen to you. And by the way, there's thousands of ways that it can be done. So it's not surprising that things can go wrong. And often the question I ask people is, how is it that more bad things don't happen? So the history of human factors in healthcare, it's been around since, I would say, 2-3 decades now that people have been talking about it, but it's only in the last few years that it's actually come to the forefront, and I'll describe why, or at least why I think that's happened. So this was a publication from the Institute of Medicine. It's an American publication in 1999, and they concluded that about 44,000 to 98,000 people die each year as a result of preventable medical errors in the US. And somewhere along the line, you may have come across this analogy. It's equivalent to a jumbo jet crashing every day. So that's quite frightening, because obviously if you've got a plane crash, it becomes news for at least a good few years. But if these things happen in a setting as what they've described in America, you can see the issue that we actually face. So the key recommendation, obviously, one of the key things was on teamwork as a mechanism for enhancing patient safety. Most of our data is from America. We've got data from the UK and Scotland, which I can also share with you. So it says here, surgical adverse events, 3 to 22% of patients undergoing inpatient surgical procedures in industrial nations. This is WHO data, so this is throughout the world really. Suffer major complications. Mortality rate is just short of 1%, which is a huge number if you think of the number of people who actually undergo surgery around the world a day. 16% of surgical inpatients in the UK have adverse events, half are preventable. And we have to also appreciate that complications do occur. That's why we consent patients, because there is a margin that's not necessarily due to error. It's just how we are. It's just due to our disease process, etc. But nevertheless, the key thing that I'm always keen to emphasize when I train doctors and nurses and physios, etc., is that a significant proportion of this is things that people can do to prevent from happening, or they are preventable. And so the key question is, why are we not acting on it? The key point, obviously, that keeps coming up is that human factors is implicated in the majority of these events. So just a quick slide, essentially reiterating that fact. There's always a huge element. It's not just burden to our patients, but it's burden to the economy, because it does cost a lot of money. But the key thing I would like you to see was what's at the bottom there. Factors are all non-technical, so it's all inattention, failure to check, haste, fatigue, distractions, and poor communication that triggers all this. So our turning point, as I mentioned earlier, the way I see it is, some of you may have heard of the Clinical Human Factors Group, for which I'm also an advocate for. It's based in London, and it's chaired by a gentleman called Martin Bromley. And he's an amazing gentleman who's done an amazing amount of work to bring human factors to the front line, if you like, in healthcare. But it unfortunately came at a cost, because the reason he took this on board and progressed it, he's actually a captain of one of the major airlines. And the reason he actually took this on and progressed it with colleagues was due to the death of his wife, which happened while she was actually being managed in a private care setting that involved the most senior people you could get in a team, which was 3 consultants. She had an airway problem, and the 3 people who were addressing the problem, if you like, were consultant anesthetists, 2 consultant anesthetists, who are the people you want in an airway emergency, by the way, and an ENT consultant, another person who you would choose to have in an airway emergency. And they were all senior consultants, but yet, unfortunately, due to a series of issues at that time, she died. And it's only when the review happened, he realized that the reason all that happened was because of complete failure in non-technical skills and shortcomings in human factors. So he actually took it upon himself to progress this work. And one of the key things, obviously, was that he kept going on about was that how we, as industries and as professionals, should actually learn from it. The turning point, as I mentioned, was one of the key things that he did with Clinical Human Factors Group was that they brought this into the forefront, and now they've got the backing of all the major regulatory bodies, if you like, that we have in medicine in the UK, supporting the need for us to provide human factors training in the health sector. So what is the human factors approach to safety in healthcare? There's a few points that we emphasize. One, acknowledge. So we accept. We need to move away from a culture where we assume we are all perfect. And as that culture has been prevalent, I kid you not, especially in specialties like surgery, you know, if you're not perfect, you show signs of weaknesses, you do not go up that ladder. And so it became quite a brutal environment to be in. And so the first and foremost thing that we emphasize these days is that we have to accept as human beings we have limitations and we are prone to error. And the idea behind human factors is how do you actually design a system or a service around you that's safe enough, that has filters in place to ensure that as and when, or if you do ever have a moment where you've forgotten to do something, an error or a lapse, that the system is safe enough that someone else picks it up, or there's a process that picks it up. We take a systems approach, and I'll talk more about this in a second. We look at the organizational management, equipment design, workspace layout, and we design workplace systems to minimize the likelihood of error. The key thing about acknowledging our limitations is what's on the right-hand side of the screen. So we talk about attention. Our attention may be limited. I'm going to be talking for quite a bit, by the way, so your attention is going to drop off very soon, right? Memory constraints, I'll talk about this again in a minute. Our working memory is limited, and I'll describe why. We talk about automaticity, right? So I came from the hospital to here, and if you ask me to recollect what I saw on my journey, I have no idea, because it's just a journey I make, right? So I'm completely oblivious to my surroundings. We talk about situation awareness. How many of us are actually aware of our situation awareness at all times? I'll talk about it in a minute also. This thing's called about availability heuristics. So we tend to give a lot of attention to what comes to our mind. As an example, in surgery, the common thing that we do is that whenever a patient comes to us and tells us a history, we already start making judgments as to what the diagnosis is, even before we actually run the tests or things, and that's dangerous. And the same thing, I imagine, can happen to anyone in your industry. Confirmation bias. And likewise, when we reach on a decision, we have an inherent tendency to go and seek approval, if you like, that I am right. You know, so we actually go and arrange our investigative process accordingly to confirm our judgment rather than to confirm what's actually right. So cognitive architecture, we talk about our memory constraints. This is a good slide. It's actually quite an old slide, work done by psychologists before, but it still holds a lot of weight. We talk about working memory and long-term memory. All of us have got long-term memory. It's why we are here where we are today, right? Because we've done our work throughout school, college, university, whatever it is, and we've got the background understanding of what we do in our profession that's embedded. The key challenge is that when you go to work on a day-to-day basis, what's in your working memory? And this is flexible. It's got a limited space, And it's very much related to what happens to you on a second-by-second basis. So an example, if I'm going to work and I'm driving and someone cuts in front of me, I get angry. Yes, I do. Honestly, I do. And so that takes up my working memory space, right? So all of a sudden, the working memory is in the bed. I know I've got 12 patients to see, or this and that, etc., things to do, and this is what I need to do today. But that space has already been compromised. And then I go and do a ward rounds. And in a previous culture, which unfortunately still exists, there's a tendency for some people to shout at other people, right? And if that happens, a junior doctor gets shouted at, and then his or her memory space shrinks. But then she has to go and do 10 complex tasks after that, all of which requires a full working memory space, but that's been compromised. So the key thing we emphasize is to, one, be aware that you're prone to your working memory being affected by everything occurring across or around you. But two, is to be aware about our colleagues. If they've been affected of whatever issues at home, journey, work, etc., and they may be incapacitated, if you like, to a certain degree, if you're going to be asking them to do any high-skilled or high-level task. A few things about myths about errors and biases. So bad people make errors. That's completely wrong. Bad people do make errors. There's no doubt about that. We do see that regularly. But the key thing is, in most of our work, on day-to-day work, a lot of us come to work to do a good job. We don't come to do something bad, but bad things can still happen. The other myth is that errors are random and highly variable. I'm sure all of you are aware it's not. If you do a review of analysis, you will actually start seeing that you can actually track those errors quite early on in retrospect. There's the other thing about errors of highly trained professionals are very rare, and this is definitely not true. The one thing that as all of us as professionals that we can do is that we can control our environment, we can control our system. In my practice, we set a lot of things. We're very strict. I'm very strict in that sense because we set a lot of filters. We set the service, the design of our environment, etc., to ensure that we address all these limitations of everyone that's working within it, including myself. So at the start of the day, before I start an operation, I'm always keen to speak up and tell everyone who's there, if I were to do anything stupid, tell me, right? Or if I forget to do something, tell me. And this is a change. This is an important change of culture. Just because I'm the most senior person doing an operation, that doesn't mean I'm going to be perfect at the 7-hour operation or 6-hour operation. There's going to be occasions where I may forget to do something or might be slow to do something else. And it's trying to get everyone on board. Errors, there's obviously errors and violations. So just very quickly, there's errors of execution and errors of planning. Errors of execution is when the folks on the front line do something that is wrong. Errors of planning, more and more we're trying to look at this. It's where we, people who design the system, may have actually designed something that doesn't work. And so folks are still doing things wrongly because the process is wrong. Now this is all different from violations. We're not talking about violations here today. Violations is when you actually know something is wrong or bad and you go ahead and do that. And that obviously comes under a different category. Active errors, we talk about slips, lapses, fixation error. Fixation error, we hear this a lot about in the airline industry, and something that we also see, where we become so fixated on one item, forgetting the bigger picture. And often than not, this item may not actually be as significant as we think it is. But then what actually happens is, in the background, everything else that can cause more harm continues to happen because we focus all our attention, resources onto this and only this issue. And then there's this other thing about saying everything but this or everything's okay. In my team, if someone keeps telling me that every time everything is okay, I start worrying about the individual. Because I actually start thinking, first, is he or she being honest with me? Because I can't imagine everything is okay all the time. Just a very quick slide based on some work that was done by Amal Bratti and colleagues some years back. It looks at driving, right? When we talk about errors, we sometimes don't just commit errors, we push boundaries, right? And the classic example is driving. So I wouldn't raise my hands because obviously there's a lot of witnesses here, but I don't know how many of you tend to go above 70 miles an hour, right? So we know if the speed limit is 60, we drive 60, we're going to be safe, because that's our legal space. If we drive slightly above 60, 64, we push it a wee bit. That's what we call the illegal normal space. So we think it's normal, but it's actually illegal. But we think, what's 4 miles more an hour going to make? In actual fact, if you look at the speed limit, the difference between 20 or 30 miles an hour is a potential life, or the difference between 30 and 40, especially. If you hit a child in 30 miles an hour, the child's more likely to survive. If you hit a child in 40, the child's more likely to die. So that's just 5-10 miles an hour actually makes a huge difference. The other issue is obviously once we start going above 75 miles an hour, so there's an illegal space for most of us. The question we always ask people in departments, organizations, and industries, where are you driving this industry, or where are you driving your department, at what speed? And the reality is a lot of us tend to push the boundaries, and we have to do that sometimes because there's pressures. There's pressures of time pressures, there's individual pressures, there's these issues of vulnerability that we actually have. And so really in designing a safer system or designing a safe organization, the key question is first identifying all your team members and just what sort of speed they're going at. Biases which affect the way errors are viewed. I put this slide up because it's quite important really. We're also aware that we are very much prone to what we call outcome bias and hindsight bias. Whenever we look at things that has gone wrong, we don't look at the human factors and non-technical skills, but an outcome bias is very much dependent. It's an example. There was a study done by anaesthetists many years ago, and they wrote up the case scenario. Then they gave a group of anaesthetists in one room the scenario, but the outcome was where the patient survived, but there was obviously a near miss. They took another group of anaesthetists in another room, graphed exactly the same case scenario, but this time the outcome was where the patient died. And they asked people to do a review, an analysis, etc. So the group where there was a near miss, or where they said it was a near miss, no harm came to the patient, majority of anaesthetists, if not all, said, you know what, that happens a lot of times, happened to me before, but it's not a major issue, these are things, etc., that maybe could have been done better. And when they went to the room where the outcome they wrote up as the patient died, all the anaesthetists, they said, I can't believe he did that. I mean, that is bad, that is really bad. We would never dream to have done that. And that's just purely because we are so biased towards the outcome. We make our judgment call as to what's happened based on the outcome rather than on the trajectory or the journey of the event, if you like. There's this other issue where we talk about error script. All the men and women are merely players. And this is something that's important in our field because it's really sometimes things go wrong is because of the script that we've written. We write the script, then we give out to all our team members to go and act out and play, and the errors keep happening. And then we either get angry with them or we fire them. And then we get a whole new batch of people to come in, we give them the same script that has an error in it. And guess what? The same thing happens again and again and again. So unless we change that script, you're going to have a weak system. We talk about systems approach, physical capability. When we talk about systems approach, this is what we mean. So we talk about physical capabilities, cognitive capabilities, organizational factors, social factors, and system. A lot of NHS organizations now are actually doing cognitive testing before we appoint consultants, etc. And it's not to identify the weirdos out there or the people who are, you're like, geez, I never want to work with him. No, far from it. It's very much to identify people's personality and traits so that we can put them in the right team. So we can identify their strengths but weaknesses also. We talk about systems. This is what I want to show you. The system that we actually talk about, it comes in different ways. Okay, when we actually do analysis of events, a lot of times we talk about how bad things happened, but we actually portray a linear model. So that's a classic example of the automobile industry. As it goes through the plant, somebody does the chassis, somebody does the body, somebody does the paint job, and if someone forgets to do something or does something wrongly, then obviously you get a default car, a car that's not right at the end of it. But the reality is we are more complex. You also have a more complicated system. And in the health sector, as I imagine your sector is, it's actually complex because there's a whole load of other things that's actually contributing to the event. So as an example, I'll show you the act of taking blood. Okay, so this is something that most of you perhaps already have had done to yourselves, right? By the way, I talk a lot about health sector. It's actually very safe. So don't go out of this room thinking, geez, never going to hospital ever again, right? It gets better at the end. So really, we talk about taking blood, and if you assume that it's a linear model, right? So you decide to take blood, or we decide to take your blood. So we get all our bits and pieces together. We take your blood, we label the blood, and send it to the lab. And I'm grateful to my colleagues in NES, Paul Bowie and all, who shared these slides with us, because he's done a lot of work on this. And it's based on this model. Most of you may be familiar with that, Jim Reason's Swiss cheese model. Okay, so where if bad things happen, it's often due to a combination of either latent issues that are already inherent in your organization, weaknesses in your system, or issues that are due to what we call active failures. So issues of individuals primarily, or issues that happen on the front line. And if you line up all those holes in the Swiss cheese, the weak points, if you like, in these systems, an error will result. Now, just think about that blood taking model, if you like, and you can apply the Swiss cheese model has got its limitations. And it's because when they went and did the work to identify what exactly are the issues to take someone's blood and send it to the lab, and it's not a linear model by any means. And this is one of the easiest tasks we do in a hospital. Anyone can do it really in an NHS hospital or any other health sector. But it's actually one of the most complex bits of work. So never mind when we have to operate or we have to do complex procedures, etc. So what you need to know about human factors, I hope this works. It's not that loud, is it?
So excited. That killed him.
Sorry, I couldn't hear that. Basically, the doctor says that killed him. Okay. So why we need human factors? For that reason, right? A whole lot of issues that we do are actually non-technical skills. You saw in that environment already. There's a whole issue. First of all, he was using the equipment wrongly. Okay. So that's already a failing or perhaps a violation. You shouldn't be buzzing flies for that. Secondly, there's the issue of communication, how you communicate it. Then obviously there's the whole situation awareness. You don't put a left right outside a patient's bed. Right? And decision making, obviously. So non-technical and so let's talk about non-technical and team skills. I'm okay for time? Yeah. I'll try and speed this up. I didn't realize we already. So some key categories we talk about: situation awareness, decision making, communication, team working, leadership, coping with stress, and coping with fatigue. This is our traditional view of clinical performance. We talk about patient risk factors. Then we talk about technical skills, your clinical knowledge, and we think that's clinical outcome. And this, believe it or not, still exists in some settings. Okay, we've always been very focused on our training people that you should be good in your technical abilities, which you should, and you should have a great amount of knowledge. And guess what? If you have these two, you can have the best outcomes. Have you realized that actually no, we're still having poor outcomes, and that's because there's more to that. They need to have the technical and non-technical skills. A lot of what we do is dependent on teamwork. It's a complete team sport in the hospital, as I imagine your organization. A lot of outcomes depend on clinical environment and procedures, and ultimately in the organizational context, and this results in the outcome. Just a key point really, when we talk about how we do human factors approach to a significant event investigation, the key thing is at the bottom there. You should not stop at telling one individual or team what they should have done to stop an adverse event. Don't just stop at that, because the event is still going to happen. It should be a more broader approach. And also don't assume that just because we praise somebody that you're going to have the same outcome again what we need to do is identify. We have this thing called learning from excellence nowadays that we do, where we take cases with great outcomes and we actually pull it apart and see why there was actually a really good outcome. And then we try and implement those models into our practice to make sure that we can replicate that. Key question is, can we improve non-technical skills, especially in the health sector? And these are the 4 things that we actually do. We talk about situation awareness, decision making, communication and teamwork and leadership. We focus on these 4 main things when we talk about non-technical skills. I'll go through it in a bit. It's quite impressive, isn't it? And to be honest with you, before Microsoft Word, that was pretty much how I used to write things, and people still read. You know, I was surprised I made it through university. So we're talking about cognitive skills, situation awareness, team observation, awareness of what's going on. We talk about cognitive skills, gathering information, interpreting information, and factors that affect our situation awareness: stress, fatigue, expertise, workload, distractions. These are key things we should be aware. It affects how we actually function. Is the line straight or crooked? Anybody? Yeah, but kind of gives away, doesn't it? It's bound to be straight, especially if you look at it, let's look cricket. A few things about situation awareness. This is my theatre, and this is how we function. So I do a lot of laparoscopic surgery, a lot of keyhole surgery. And we design it, or we make sure that it's designed such that it actually supports us. So where I stand and where I operate is away from the door. So people keep walking in and out. It doesn't distract me. Historically, that has happened where surgeons have committed error because people are walking in and out and they get distracted and they forget to do something or they do something wrong. This other example, if you like, of how we've actually gone on to design better things in the health service. And I don't know if you can see the knobs there, but essentially all those levers, they are oxygen, nitrous oxide, and air. And these are things that the anaesthetists have to adjust when you go under a general anaesthetic. And historically, they all felt the same. Now they are all manufactured, that they all feel different. That the anaesthetist, even if there's a power cut or if he's looking on the other side attending to something else, by feel, he or she knows what they're actually putting up or down. We mentioned about the airway issue that Martin Bromley and colleagues had. What Martin had with his wife, where they couldn't establish an emergency airway. One of the key things that we've learned from that, and what we do nowadays, is there's this kit that's plastered on the wall in the anesthetic room in all hospitals, because they know now that if they are struggling looking down, that what actually happened was there was a fixation error. They got so fixated on trying to put a tube down and trying to establish airway that they forget the time was running. And you know, you can only survive after so long without oxygen in your brain. And what actually happens now is that when an anaesthetist is actually doing this task, if he or she looks up, they see that. So automatically it reminds them that if I'm not getting an airway, that's my emergency airway kit. Decision making, there's a few things just to be aware of. There's 2 types we talk about, intuitive and analytical. A lot of folks historically used to think that intuition is a good thing, and it is. Intuition is based on experience, but intuition is also based on our biases. Because something good has happened because we applied method A in the past, that doesn't mean it's going to work out again, unless you've got evidence behind that. So we have to be careful with intuition. Surgical decision making, like a lot of what you do, would be quite complex because it's just not 2 types really. It's just not intuition and analytical. A lot of it is also on rule-based. We've got policies, guidance, and sometimes we do have to be creative in how we actually resolve problems. Just a few things to be aware of, really. Some contributing factors that can affect all your non-technical skills, and one is fatigue. Studies have shown that if you actually miss sleep for 24 hours, that's equivalent to you having 0.1% alcohol in your body. To put that in perspective, you're twice over the limit in Scotland. Right? But we still allow people to come to work and do work, but we wouldn't allow them to drive a car if they had that amount of alcohol in their body. Excessive workload, dealing with patient suffering, dealing with error and insufficient professional support and training, all these can have an effect on your non-technical skills ability. A few things that we usually put up to help colleagues with stress and fatigue, to be aware of when we're helping colleagues, if you like. Common mistake we do is asking people to work harder. That doesn't work. Physical illness is often a manifestation of a stress environment, addictive behaviors, anxiety, depression, and obviously anger and violent behaviors. Communication, key thing really. I won't go too much into detail with communication. You know the importance behind it. I'll show some examples. By the way, does anybody who thinks that communication is mainly non-verbal? By show of hands. Yes. So historically, everyone believes that. It's actually not entirely true. It's actually based on a flawed study. If you Google Alfred Mirabia, you'll see it. He's actually based on a study that they did, but they had very selected demographics, if you like, and so the methodology was flawed. Communication is actually more complex than that. It's got element of verbal, non-verbal, but especially now we use a lot of other means to communicate. A few things that we teach our clinicians, trainees, etc., on listening skill sets. The things that you do, you ask questions, you can paraphrase, you can probe, pay attention, make eye contact, positive body language. What you don't do is start debating what is being said in your mind. So a lot of times we do that. We already start thinking of an answer when someone's talking. The rest of it you pretty much know. An example of how that affects us in surgery. So they looked at all the adverse events on wrong site surgery. So this is where people getting the wrong limbs operated on or wrong side of the body operated on. And the key reason behind that was communication. This is what we've done in the health sector. So a lot of work that's come at WHO, Atul Gawande and colleagues from the US, etc., was establishing what we call the surgical safety checklist. And there's 3 steps to that. But one of the key things with that step was before we start an operation, we get together as a team and we talk about the operation. We address key questions or key challenges we're going to have. I don't have a slide to show you, but we actually have evidence to show that there's a significant association in reduction in mortality here in Scotland since we've actually established that. It's obviously an association rather than true cause and effect. Not much on leadership, but the fact that we always emphasize on collective leadership. The most important determinant of an organization's culture is the current and future leadership. And when we talk about collective leadership, we usually ask everyone in our team to assume roles and responsibilities, to actually feel accountable, if you like, in terms of patient outcomes. We talk a lot about just culture now, and that's something that we are very keen on. I keep pressing onto our team. Just culture and accountability. So accountability is not that something wrong has happened and it's all your fault. Accountability that we are trying to build is that something bad has happened, but now it's your responsibility to lead a team or to get a team together to identify why it went wrong and improve from that. Now, we've done a lot of work. In fact, there's a lot of great work happening in the Royal College of Surgeons in Edinburgh with colleagues also on team training. We realize that the best outcomes we get is when you actually have an effective team. This idea that you can have a lone clinician having great outcomes is a fallacy, really. Features of an effective team. We know that everyone has the ability to perform their task and abilities to work effectively in a team. Working skills required to support others, solving conflicts, exchange information, coordinate activities. We do a lot of these days, simulation in Aberdeen and elsewhere. We put trainees in stressful environments and see how they behave and see where their shortcomings are, and then we try and address that and improve on that. A few things on rudeness of work at work. Historically, this was almost neglected, forgotten, ignored because it is expected part and parcel of how we worked. We now know that that's got a direct bearing on patient outcomes and outcomes in general as to how that team functions. So if someone is actually quite rude, you can actually have really poor outcomes. There's a lot of work being done by the Institute of Healthcare Improvement on this also. And they've actually even suggested that even if you have an expert in your team, but that person is actually very obnoxious, it's not worth the effort because your outcomes are still going to be poor. Resolving conflict, few points that we usually put forward. I would say the last line, be careful. I've seen some people try and use humor, it doesn't work. And so if you're a funny person, do it. If you're not, stay away from it. Can we improve non-technical skills? The question is yes. We've done a lot of work, and we are continuing to do a lot of work in the health sector. The implementation of the surgical checklist was us supporting that communication aspect. Simulation puts colleagues in under a stressful environment so we can identify weaknesses in non-technical skills. And we obviously are designing better, safer environments for us to care for our patients. We've got a huge amount of individuals, groups, bodies here in Scotland who are actually very proactive in progressing this work. More recently, the program that I lead with the Scottish Mortality and Morbidity Program, it's to try and identify issues that has resulted in a patient having a complication, a near miss or a death. Most deaths do not happen due to an error, but nevertheless, there's still things that we can actually learn from or improve. In medical school, they spend a huge amount, got colleagues in the university, Rona Patey and colleagues are doing exceptionally good work on implementing training for undergraduate students. A lot of good work. We've actually got a lot of great work that's actually happening in our health sector, and a lot of this work has stemmed from learning from other industries such as yourself, the airline industries, etc. The key message, the key take-home message that we usually emphasize is that we can't change human behaviors. Human factors is not about that. Human factors is not about me psychoanalyzing you and trying to change your behavior by any means. What we intend to do with implementing human factors or understanding human factors is very much getting you to understand your environment, getting you to change the processes, change the design of the environment around you such that he can support you. And that's really what we intend to do, or what we're trying to do. So yeah, thank you. Yeah. Oh,